So, uh, yeah, I'm basically a cardiac surgeon. I'm basically a cardiac surgeon by training, and I work here in the heart and lung transplant as well as cardiac surgery at Artemis Hospital, Gurgaon. And I'm extremely happy to be, speaking to you guys again in just over a month's time, as organized by Jivo and Varun. So today we're basically going to discuss what is the management of coronary artery disease. I understand that all systems may not be as equipped as others. So, so I will try to speak on how to manage the coronary artery disease in a resource constrained environment as well. Um, it is always good to have a little bit of shortcomings or constraints in your life because I believe that makes you a more able physician. So starting right away, does it change? Okay, yeah. So basically, what we mean by coronary artery disease is our heart has about two main arteries, the left and the right artery, and whenever there is a blockage in those arteries, is what causes a coronary artery disease. Um, so we basically need to identify coronary artery disease early in their presentation. So anybody who's got a bit of chest pain, who's a bit of dyspnea, or which is shortness of breath, who kind of gets fatigued very easily, bit of pain in the legs, a generalized feeling of not feeling well, a bit of weakness is what would predominantly be your symptoms. So once you have either of these symptoms, the best way forward is to probably go to your general practitioner, see him, and tell him that, oh, well, I've got a bit of chest pain, or I'm getting breathless very easily, or I'm not able to do independently those works which I was able to do about a month back or maybe a couple of months back. So early in the journey of your coronary artery disease, whenever you have these symptoms, you need to go and meet a practitioner. It is much possible that these symptoms will definitely appear in your journey or in your coronary artery disease presentation much earlier than you would have what is a myocardial infarction or heart attack. So I've just the first graphic says know the difference, how it is different, how a heart attack presents differently between a man and women. So women by nature will have what is like a classical jaw pain, a bit of shortness of breath, a bit of backache, and will have extreme fatigue, or also at times the feeling of vomiting and nausea. Men, on the other hand, will predominantly have sweating, a bit of heartburn, which can be very confusing with a esophageal reflux disease. We often tend to take those antacids and other things to kind of kill the heartburn. But if your heartburn persists for anything more than half an hour after having your antacids or your other medications, the common over-the-counter medications for heartburn and indigestion, the best thing is to go to your general practitioner immediately. Um, so next we're speaking on heart attack. So what are the symptoms, signs and symptoms? Heaviness in the chest, cold and sweaty palms or cold and sweaty body extremities, pain in the neck, pain in your left arm, which is radiating from your shoulder downward, a sudden feeling of extreme nausea. The symptom onset of symptom can be very sudden. You might be sitting, you might be walking, you might be in the middle of a meeting, and you're suddenly feeling very short of breath. You're suddenly feeling very sweaty. You're nauseated. You're almost feeling like throwing up. Your shortness of breath, and you're feeling very tired. It is more common that in people above 40 years of age, this is the presentation of what is an heart attack. Diabetics have to be extremely careful because they may not have many of these symptoms because of symptomatic or sympathetic dysreflexia. So they will have lesser chest pain, but they'll still have this sense of nausea, sense of extreme tired, and they will have cold, clammy skin, extremities. So they have to recognize that they may not be having as much pain, or they may not maybe underreporting that a little chest discomfort would otherwise have been a full blown chest pain. So diabetics need to pick up, need to be made aware by the physicians, and also need to pick up their coronary artery diseases with a much more subtle presentation. Women in the reproductive age group, by the design of God, are blessed to be protected against majority of cardiovascular disease because of the female hormone estrogen, which kind of prevents or which kind of precludes you from disease of the heart. But even then, it has been seen that perimenopausal or menopausal women often do present with symptoms like runny nose, flu, a feeling of indigestion and heartburn, and they might also be having the symptoms for a few days. When men might come to you with a chest pain for a couple of hours, a women might come to you and say that I've been having this thing for the last 3 or 4 days. And we need to understand that women, by design, have a slightly longer presentation of coronary artery disease or myocardial infarction in the perimenopausal age. And so we need to be very careful. If somebody is saying, oh, we have been having chest pain for 3 days, and we're yet alive, we're yet in your clinic, we have not collapsed, and she's a lady, more often than not it is what is called as an MI in evolution or a myocardial infarction in evolution, and you need to definitely send her labs, send her cardiac troponins, and treat her as a coronary artery disease unless proved otherwise. So an immediate ECG, immediate bloods, and immediate testing of troponin T on a kit is what is the minimum that is required to effectively treat a coronary artery disease in women or a diabetic, where you need to be very cautious, careful, and pick them up earlier than in a standard adult male who will come with a full blown chest pain, radiating in the neck and arm, cold and clammy extremities, heavy chest pain, extremely tired, short of breath, won't be able to speak. So, and when you pick an heart attack, my next slide will be how do you respond to it? So, there are multiple ways of responding to it. The first thing I've put in a picture on the bottom left about the Bayer aspirin, because I know that Bayer, for a reason that Bayer is very easily available in all of the African continent. So having a aspirin with you or with your general physician is extremely important, because should you be able to take 300 milligrams or 3 tablets of 100 milligram aspirin, you are more often than not assured that you have bought yourself some valuable time to go to the nearest medical facility, to go to your GP, and not collapse to a myocardial infarction or heart attack. So 2 tablets of 150, 3 tablets of 100, or a single tablet of 300 milligram aspirin is what an adult should take. Should she feel or should she be in a situation which is resource constrained, does not have a percutaneous intervention facility in less than 120 minutes, and which is basically 2 hours, or the golden hour has now slightly extended. So we say that even if you connect in the first 120 minutes, it is worth the effort. So yeah, if PCI is not possible in less than 120 minutes, then you need to go down the medical pathway where you will be put on dual antiplatelets, and you will be kind of fibrinolized with a antifibrinolytic drug, or with the fibrinolytic drug, antithrombin drug basically, and you will carry a slightly higher risk of bleeding, say higher risk of bleeding than the normal person who would be put through a
Anyway,
intervention, but that
um,
may be a lifesaver
ebe
for you.
mụ na gị na Chukwudị na-ejezi ikodo ndị ajụ ụlọ ife na platfọm anyị gbachiricha m nkịtị.
I
Nke
couldn't
ka
get you. What is the question?
emere na ike ịza.
Repeat your question.
Please repeat your
Ị
question.
na-eje nke Ifeanyị
Yeah, Dr. Gozi, we could not understand your question.
ga-esi ebe
Repeat it.
ewo sorry. Oh, I wanted to go with you.
Okay, you can, Dr. Biswarup will be happy to answer if you can repeat your question, or you can type it in the chat.
The other time club with Jerocom, and last year Angel Walker community, over last year, 2 years ago, whatever. What time that time Angel installation. No, Walker, it was very good company.
Okay.
Is my screen still visible?
Yes, sir,
Okay.
it's visible.
Well,
Dr. Gozi, we were not able to understand, comprehend. Like, if you can type in the chat, Dr. Biswarup will be happy to answer. Dr. Biswarup, we should continue.
Okay. Okay. No worries. So, in a resource constrained setting, the best you can do is take 300 milligrams of aspirin. Go to your doctor immediately. Should there be uh, non-availability of a cath lab or a percutaneous intervention in less than 180 days, your way out is basically fibrinolysis with antithrombin drugs or be put on prasugrel aspirin. I understand there will be slightly higher risk of bleeding, but something is better than nothing. So yeah, that is the kind of I've just lost my this thing. View as an or it's multi-speak now. Okay. Just give me a second. I just lost the thing. Yeah. Just let me show. Yeah. So yeah. And if there is a setting where PCI or a percutaneous intervention is possible in less than 2 hours time, so then our primary aim should be, yes, you should still have the aspirin 200 milligram, and then you should be put through the primary angiography pathway. Primary angiography has a much better chance of resolving your heart attack or your myocardial infarction. As a general practitioner or as a physician out there, this is probably one of the key things that we need to understand, is how they would present in an ECG. So this is what is a normal PQRS echocardiogram, electrocardiogram will look like. This is a standard ST elevation MI. You can see that the ST segment is elevated, and this is what is a non-ST elevation MI where the ST segment is depressed. So these three patterns, somebody presenting with chest pain with an abnormal ECG, with or without the presence of cardiac enzymes, you need to suspect and have a very high index of suspicion that it is a case of myocardial infarction. Decide whether you have a PCI capable facility or a PCI non-capable. If it's a PCI non-capable facility, your answer probably is um, your answer probably is then aspirin with prasugrel or fibrinolysis with streptokinase. I've intentionally put the picture of this EC kinase, which is an Abbott drug, because it is widely available across all continents. So 1.5 million units or 1,500,000 units infused over a 1 hour period is what is the standard dose of streptokinase that is to be given to somebody who's having a myocardial infarction. A very easy way to confirm myocardial infarction, apart from the ECG physical findings, symptoms, and signs, is this troponin T kit, which is again manufactured by a German company called Roche, based out of Switzerland. It is almost available across the world in the same brand name called as Tropti. So you kind of put in your blood sample in this well, and if you see two red lines, then it indicates that you have returned a positive test for what is a myocardial infarction. But none of this alone will serve you enough. You need to have an ECGA, presence of symptoms of an ongoing angina or extreme, heartburn, chest pain, along with a positive enzyme, is what concretely makes up for the diagnosis of a myocardial infarction. If such is the case, and you are in a PCI setting or a percutaneous intervention setting, do an angiography within the first 2 hours. Not in a PCI settings, give the patient aspirin and prasugrel, or fibrinolyze the patient with streptokinase 1.5 million unit for adult. Coming to how to know the signs, well, I've discussed them: that chest pain, nausea, vomiting, fatigue, shortness of breath. Now we should come to the prevention of it, which is also a very important topic. So no smoking, having a healthy diet plan, routinely managing your stress quite well, not being overstressed, probably a bit of exercise, probably a bit of meditation, maintaining a reasonable healthy weight, a BMI somewhere between 20 to 25, and having regular blood tests so that you know what your findings are, you know what your numbers are, you know your diabetes measure. So as general physicians engaging with patients that have coronary artery disease, we need to be on top of the game. As in, we need to be regularly asking them to do their blood tests, do all the supportive measures like yoga, meditation, regular exercising, living a reasonably healthy life where cigarette has no place in your life. There has been some controversy on the effectiveness of red wine or no red wine for heart disease ailment, but the American Heart Association has come up with conclusive proof that any amount of alcohol is injurious to your body or to your health. So no smoking, no drinking, regular management of stress, regular exercise, a regular healthy diet plan, and kind of managing your weight reasonably to be in the 20-25 BMI range. And your doctor, or we as doctors, need to ask them to regularly be getting their blood tests done to know their numbers precisely, to stratify them into high, moderate, and low risk patients who would be walking into my clinic. um, Treatment lifestyle changes definitely play a role for stable coronary artery disease. Some medications like high cholesterol, high BP medication will help you to manage your hypertension and dyslipidemia. And if you are diabetic, you need to manage your diabetes really well. Should all of these fail and you have what is an MI or myocardial infarction or heart attack, then you will probably have to go down the angioplasty or the bypass surgery pathway. So this is for the practitioners. This is a brief. This is from one of the NHS guidelines from the UK. So this is a very basic, panel of blood tests that you need to do on everybody you suspect to have a high CVD or cardiovascular disease risk assessment score quite high. So anybody with those things, you need to do this basic profile to get this thing. So you basically do a full blood count to know whether it's anemia, infection, or any blood clotting anomaly. You need to urea and electrolytes along with creatinine to know the kidney status, which will enable you to choose a lot of your medications, a lot of dyes for angiography and other things. A liver function test, which prior to the troponin,
Yes, sir.
I didn't get you. Is there a question?
No, I think so. That was an accidental unmute.
Oh,
So,
okay. So yes, we need to know our liver enzymes, because liver enzymes prior to the troponins, the SGOTs, SGPTs, were the markers used to identify myocardial infarction for a very long time. We need to know our clotting profile, central clotting profile as to the APTT, INR, so that we can put them on effective anti coagulant therapy, whether be it warfarin, whether be it unfractionated heparin or low molecular heparin. Every diabetic needs to know their HbA1c every third month and exactly present you the number, or you as a physician need to know which patient has what number. Maintain a database, maintain an EMR, whatever it takes. Do the hard work, go the extra mile, and you will be able to classify or stratify your patients into different risk categories. And you would know that the higher the risk category, the stronger the suspicion for a heart attack, the quicker you treat a heart attack, and the better the results are. Brain natriuretic peptide, BNP, and C-reactive proteins are basically inflammatory markers which are caused due to heart failure and heart muscle damage. So high BNP, more than 1,000, would always indicate somebody with a bit of heart failure who is more usual than others predisposed to coronary artery disease. A high CRP might also indicate that you've had a recent myocardial infarction in the last 1 or 2 days. Your CRP will be elevated. It is not infection. You need to understand it is inflammation that has triggered the C-reactive protein to go high. Um, Coming to the proper treatment of coronary artery disease. So, coronary artery, as you can see, there are two coronary arteries, the left and the right. So, the left main bifurcates into what is known as the left anterior descending and goes behind the heart through the circumflex artery. So, should you have any block in the left main coronary artery, coronary artery bypass is probably a better option for you rather than um, uh, um, angiography or a PCI. Because there have been multiple trials, multiple studies, the Excel study, the Noble study, and they've had some contrasting results, but it's generally accepted in the scientific parlance that anybody with a left main coronary artery disease is probably better served by an CABG operation or a coronary artery bypass grafting rather than straightforward percutaneous intervention. Having said that, we still need to emphasize the importance of percutaneous intervention, and that percutaneous intervention may also play a role in temporarily stabilizing these patients who are evolving
Dr.
with the
Biswarup,
myocardial.
Dr. Biswarup, there is a request. I mean, the pace a little bit slow. Some people are
So
not able.
sorry. I'm so sorry. I just get very excited with coronary artery. It's something very close to my heart. No worries. So we'll get back to the basics of coronary artery disease again. So as we understand that our coronary arteries are basically classified into left and right, and this is, I will just show you the pointer. So this is basically the left main coronary artery disease. So should anybody, any of our patients who's a high risk patient for a heart disease, have one of the main coronary or the left main coronary involved, which is identified in the angiography. So he is a better candidate to receive a bypass grafting rather than a coronary stent. Having said that, coronary stents still have a large role to play in their management, as in they might be stabilized with what is called as a PCI or a stenting or a percutaneous intervention for the time being, so that their heart can regain back some of their function where all of it cannot be regained back. And then you kind of send that patient for a surgical or a CABG, which is coronary artery bypass grafting revascularization. So any left main disease, anybody where the angiography report says there is a left main involvement, you need to be very cautious as to what therapy you are suggesting them. More often than not, it is scientifically accepted beyond a doubt, beyond the RCTs or the randomized controlled trials, that coronary artery bypass grafting has a much longer period of disease-free survival for these patients. Okay. Coming to the syntax score or the calcium load. So if the calcium load in the coronary is very high, it is a very complex anatomy. There is a score called a syntax score, which is done by cardiologists. It is online downloadable, so you can go to the syntax score website and just download I'll provide the link, download the score sheet, and you just fill in the forms according to the findings that you have generated, and it'll give you three different classification of scores: a syntax score of less than 22, something between 23 and 32, and something more than 32. So anything less than 22, a low risk patient is probably best managed with a percutaneous intervention, but those in the moderate or high risk zone are definitely better managed with a coronary artery bypass grafting or CABG surgery. Coming to multivascular diseases, there have been some centers that have been doing very well stenting these patients, but this is not a very replicable practice. So it may not be possible in a resource constrained setting to be doing a very good PCI in a multivascular disease, and in those cases, a coronary artery bypass is your option of choice. Coming to blockage of the um, right coronary artery. The right coronary artery can be extremely tricky, as in the right coronary artery might present without a chest pain, or just present with what is in cardiac arrhythmia. Patient will have irregular heartbeats, and we would be kind of trying to treat the ECG rather than picking up the coronary abnormality. So we need to be very careful. Anybody of the age of 40 with any cardiovascular disease risk factors, should they have any arrhythmia in the ECG, which is not simply comprehensible, it is very reasonable to get either a coronary angiogram or send them to a specialist for further treatment and referral. Coming to the longevity of coronary artery disease treatments, stenting vis-a-vis CABG or bypass grafting. A bypass is a much more reliable, long-term, stable, and reproducible operation, which will have a longer disease-free life, somewhere in excess of 10 years, maybe 15, maybe 20. Whereas a stent is a limited time stopgap arrangement. The newer stents, they say, kind of last your lifetime, but more than 10 years is a rarity. So should it be a young patient has more than 10 years to his life, you should more often than not get one of the bypass surgeries rather than the stenting. Is the pace okay?
Yes, sir. But
Okay.
I mean, the slower the better, sir,
Yeah,
because
no worries, no worries. I
yeah.
mean, I can. Should anybody have any question at any point, just feel free to ask me, or just feel free to let me know. I will slow down. I'm more than happy to kind of um, repeat myself. No worries on that front.
Okay, sir. Okay, sir.
Um, so the key home message is left main coronary artery bypass grafting, younger patient bypass grafting. In both these cases, stenting or a cath lab has a role in stabilizing them for some time. Younger patients who have minor disease that does not need a CABG can also be managed with a medical management. But older patients, frail patients, people that do not want to be in the hospital or can't be in the hospital for very long, want to have a short hospitals say for them the ideal is PCI or stenting. Stenting also has a role in acute myocardial infarction within the first 1 hour of presentation, which is called as uh, percutaneous intervention of acute myocardial infarction, or PAMI. So PAMI definitely has a role in acute management, but long-term management of left main disease, long-term management of younger patients, long-term management of complex coronary disease is not stenting alone. A lot of it is very well managed by coronary artery bypass grafting. So this is a slide. I will share the image, which is favors stenting patients with severe comorbidity, advanced age, frailty, reduced life expectancy, restricted mobility. Syntax score less than 22, as said. Anatomy likely resulting in incomplete revascularization of CABG due to very poor quality of vessel or extremely poor quality of conduit. Say somebody's got a disease in the leg where you can't take a vein, or somebody's got some chest wall abnormality which precludes you from harvesting the memory artery, then yes, percutaneous intervention or stenting is probably an option that can be favored. But diabetics, reduced LV fraction, left main coronary artery disease, severely calcified coronaries, high syntax score, any pathology in the ascending aorta, it is always a better option to provide these people with a CABG. Uh, Coming to left main diseases, as we have said that the accepted practice is a CABG, still there is a minimal role of PCI in that zone. So PCI is a quick, easy fix with the rapid recovery, and they do reasonably well in the first month. But should you want a long-term recovery, should you want longer life at 2 years, should you want durability as the criteria of choice, then coronary artery bypass is your operation of choice. There have been 4 randomized trials to this effect: Syntax, Noble, Precombat, and Excel. Of these, the Syntax and the Precombat trials have looked at this PCA versus CABG debate for almost 10 years, and they have come up with CABG as a recommendation for long-term disease-free survival. There will be another subset of patients which my general physician friends would be encountering very frequently, are people with stable angina. So people with stable angina are those that have had some coronary artery disease, have not had a heart attack, and are still coming to you with some of the symptoms like fatigue and chest tightness, and you see their enzymes are normal, ECGs do not look very haywire. So you decide, or you kind of diagnose them as having what is known as SCHD, or stable coronary heart disease, or stable coronary disease. So whenever there is a stable coronary disease, our thing changes, as in we start their therapy for angina with one of the antiplatelet medications, which is basically aspirin along with clopidogrel. We also ask them to promote lifestyle changes, inculcating a bit of exercising, bit of healthy diet to kind of cut down on the dyslipidemia part or the cholesterol part. And should we be doing it the right way, then we can kind of delay the progress of the disease to a reasonable time where we can avail a specialist referral for treatment. Right? There is definitely a role of what is called as a GDMT, or goal directed medical therapy, for these patients. So this is a diagram from the Orbiter trial, which went on to see how these stable anginas do on OMT, which is optical medical therapy, vis-a-vis coronary interventions. And they have found that obstructive coronary artery disease uh, do much better with some active interventions, which is possibly either a CABG or a percutaneous stenting. Um, Obstructive coronary artery disease in stable patients, it has been seen that for women who are kind of a bit more frail than men, it is the percutaneous intervention which is better. Um, we have also tried people on optimal medical therapy without stents or bypass, and they have also kind of gone on to do reasonably well in the ultra short period, maybe the first 6 months, 1 year after the onset of the coronary disease. But it is not a long-term fix. Long-term, you either need a stenting or you either need to have a surgery to kind of fix your coronaries. Um, and yes, we cannot provide everybody the same recipe or protocolize the treatment, so it is a very case to case, person to person varied thing. We kind of look at the patient in detail. You kind of identify that he or she has got what is a stable angina, or he or she is kind of getting a myocardial infarction, and then decide on a modality of treatment to offer them or send them to an expert here. So these are the two extremes of images. On the left is what you see is drug-eluting balloon expandable coronary stent, and on the right you see what is total arterial coronary artery bypass grafting. So in today's world, total arterial coronary artery bypass grafting is probably the most suitable option for anybody undergoing any revascularization, be it surgical, be it interventional. For any coronary artery disease, it is always better to replace an artery with an artery. These are some of the images from the total arterial grafting, where you do not take any veins from the leg and kind of manage all the grafts from arteries in the chest wall. It is a very frequent practice of ours. We do almost 60-70% of our coronary, or I do 60-70% of my coronary artery disease cases as a total arterial revascularization. So I've revascularized somebody only the night before, and he is kind of awake today. His heart functions have climbed up at 10% from 40 to 50. He's off all inotropic medications and he's kind of mobilized himself. So that, and he does not have an excess pain in the chest or non-healing issue. So a coronary artery disease is best answered with an artery for an artery, a total arterial revascularization technique, which we very commonly practice in Artemis, in my clinical practice. So this is the big picture. This is how the coronary artery bypass grafting will look like. We'll put in a metal retractor across your chest, split your breastbone open, and we see your heart. We place this um, device known as the octopus to find the coronary arteries where grafting is required and kind of stabilize the heart and perform the grafting. Uh, to the next slide. So this is one of the biggest articles that was published in the Annals of Thoracic Surgery, and it shows that for about 4,000 patients between 2011 and 2018, almost 2,700 of them underwent a percutaneous intervention or stenting, and only about 1,902 of them actually underwent a CABG. We have seen just about half the mortality with CABG at 13% vis-a-vis 26%, and we have seen almost half the problem with strokes and other comorbid conditions, or major adverse cardiovascular and cerebrovascular events after coronary procedure. About 28% of CABGs get it, and about 60% of stentings get it. So CABG with arterial conduit in a patient with coronary artery disease have improved long-term survival and much reduced adverse effects. So the therapy of choice that I would say, not because I'm a surgeon, but because you deserve it, is a total arterial coronary artery bypass surgery. So whenever you come for a referral, whenever you send somebody for referral, do suggest in your referral note that you need a total arterial revascularization performed on your patient if it is even remotely possible. And that changes the fate of the patient in the decades, not the years, the decades to come. So that would be from my side. I would not confuse with any more graphic or any more data. Thank you,
No, no,
guys, and
thank
I will open it for a discussion now.
Yeah, Dr. Biswarup, yeah, thank you. And many doctors, they have requested to
Yes,
share a copy of the presentation. After this,
absolutely.
you will share with me, and
Yeah,
I'll
I
ask
will
my teammate to
share
share
with.
it across with all of the participants who attended today. Uh,
Yes.
along with the certifications one next week
Yeah,
when we
absolutely.
happen.
Absolutely.
But we will share the presentation today. So
Yes.
now, sir, the first question is like you have covered the topic broadly and you have shared a lot of insights.
Yeah.
Many times, a general practitioner practicing there, the
Yeah.
question they face often is, so how to
Yeah.
determine the complexity of the case? Because that
So
determines whether they decide to
yes,
handle
he
it
needs a reference. So
domestically or refer
com-
abroad.
complexity, if you go to this slide, so complexity is generally determined by the workup. So if your enzymes, your troponin enzymes are very high, if your symptoms are not getting any better even after the first 5 or 6 days of therapy with a medical practitioner, is when you understand that there is something more to it. Just miss that. So your cholesterols might be haywire, everything might be haywire, but the thing to look out for is the troponin and the creatine kinase enzyme. If the enzymes are increasing, if the symptoms are worsening beyond 70 to 96 hours of treatment with conservative way, which is probably antiplatelet medications, um, which is the PCI not possible pathway where people have been thrombolized, but still their symptoms persist. The ECGs have not come back to normal. You need to make a specialist referral so a specialist can see, do a cine angiogram, and determine what is the severity of the disease.
Yeah, sir, Dr. Boris Pachinko, he wants to discuss a patient case with you. Dr. Boris,
Yeah.
please go ahead, unmute yourself and discuss
Yes,
this
please.
directly with Dr. Biswarup.
Yeah, please.
Dr. Boris?
Yes, good evening, good afternoon, Doc.
Good afternoon. Good afternoon.
Yes, I'm Dr. Boris Panamenge. I'm a general practitioner in Zambia
Yeah.
at Max here Hospital. So, about 1 week ago, I think this week that is ending, we
Mm.
had a patient that presented with typical symptoms of angina.
Yeah.
We managed him with nitroglycerin, which we managed to bring him back to his baseline state. But the history of his presentation is a bit complex in a sense that the patient gave a history of 2 years of that chest pain. And the way
Okay.
he characterized his chest pain was that whenever that pricking sharp pain comes in his chest, he feels like, number one, he's out of breath, he has shortness of breath, and also he feels very weak. And if he's alone in a room, he needs to basically hit on the wall, make a form of a noise for someone to notice and come quickly to undress him, to try to ventilate him. Like
Okay.
he feels like he wants to die, basically. So, and that has been going on for 2 years. He
Okay.
did a series of investigation. He did 2 ECGs that were unremarkable. Everything was normal. Maybe one ECG gave borderline bradycardia, but the second
Okay.
ECG showed normal sinus rhythm ECG. He did
Got
echo
it.
twice as well. The first echo, the only thing that was seen in the echo was mild tricuspid regurgitation with normal vasculature, and ejection fraction was also normal. I don't remember the exact figure of the ejection
No worries.
fraction. And he did 2 echo, the first echo and the second echo. The second echo that was done at our hospital was normal. No abnormalities were
Oh,
found. Then
okay.
when we did the blood test, exactly the one that in our presentation. We did the hemoglobin A1C, we did liver profile, we did urinase, creatinine, complete blood count, protein profile. All of them came back remarkable as well. And
Okay.
we did Holter ECG just for 24 hours because of the cost. The patient couldn't afford the longer one, so we did 24 hours. It only were able to pick just or PAC, the premature atrial contraction and premature ventricular contraction, but at a rate of 0.07, and for the PVC was 0.05. That was very low. Just basically nothing was there. where there were no evidence of arrhythmia, nothing. But the only thing that we couldn't do was the CT coronary angiogram and angiography, because at our hospital we do not have the reagent. So we tried to contact the other hospital, UTH, but he was asked to see first a doctor from that hospital in order for them to go ahead with the CT coronary angiography. But my question now becomes that in that particular patient, which has been having that prolonged history of chest pain with those symptoms for 2 years, getting better with rest and or nitroglycerin, and with all the tests that are negative. And I know one thing is that negative tests do not mean that there is no pathology there. It just means that you need to, probe a bit further. So
Sure.
at the end of the day, we ended up referring him to the National Hospital.
No worries. Thank you, Dr. Bori. So, I'll basically sum it up this way. So this is a gentleman with 2 years of chest pain, which comes when he's exerting himself, goes away at rest. Blood workup is unremarkable, but you did say that one of the ECG picked up a bit of bradycardia. So what I assume is that this gentleman probably has, I spoke about it, is a right coronary artery disease, and it will be extremely tricky to pick it up on a blood workup or kind of pick it up even on a CT angiogram. So what he rightly needs is a cine angiogram or an invasive angiography. Should we not be in a position to do such, then we need to put him on what is a dual antiplatelet therapy with aspirin and clopidogrel. So 75 milligram of clopidogrel and 150 milligram of aspirin once a day. We need to put him on a statin to make the coronary plaque stable. At least 40 milligrams of statin once a day, atorvastatin or rosuvastatin, right? And we need to kind of do a set of cardiac enzymes at the time when he's getting his next chest pain. So if he's got a positive enzyme, unremarkable ECG, unremarkable blood workup, everything else returns to be normal, he would be classified as what is called as an unstable angina. Because the unstable angina does not by definition need to have a ECG change. It can only be a cardiac troponinemia or enzyme derangement along with chest pain, which will classify him as an unstable angina. Should he have the resources, should he have any government funding or funding from any organization, he should ideally have a cine coronary angiography, identify the culprit lesion. How old is the patient, if I may ask you, sir?
Patient is 38 years old.
Okay, so he's young, and has he got any history of smoking?
No history of smoking, no history of alcohol, no family history of cardiac. No, but there's a family history of cardiac illness. The mother died of a cardiac disease related.
So he's got a strong family history. He's a young guy. He probably has got coronary artery disease, so needs a coronary angiogram. If there is a lesion in the right coronary artery, which is fixable with the stent, we should fix it. If not, then he needs to see a further surgical specialist who will interpret his angiogram and tell him whether he needs a coronary bypass or a stenting, or he can just be put on medication. But having a coronary angiogram is kind of cardinal in the pathway of his management. So even if you send this patient abroad, the first thing he should get is a coronary angiogram, which will decide whether he is for a angioplasty stenting or he is for a bypass surgery.
Okay. And I wanted my next question was basically on there's a score that a colleague asked me to check.
Yeah.
And he scored a 10% on that score, which was coronary. I would text the name of the score.
No worries. Are you talking about the Euro score 2 or the Syntax score?
No. Not those ones. I will remember it and then I will text it.
No worries. You please send it to the Jivo team and they will get back to me, and I will come up to you the best possible answer, sir.
All right. The final question.
We can share the context and that score, and we will share it with Dr. Biswarup, and he will
right possible answer. There's no doing.
So the last question, my last question was on the where you were talking about the coronary artery disease in female and also in perimenopause female.
Yeah.
And also, I wanted you to explain a bit more about the coronary artery disease in diabetic patient. You mentioned something about sympathetic dysreflexia.
Yeah.
I want you to explain a bit more on that. I
So,
missed.
so women before 45 are quite different. They have high estrogen level in the body, regular ongoing menstrual cycles, which kind of gives them a phenomenally good cardio protection. But the same person after the age of 40, 45, whenever they hit their menopause, their risk of coronary artery disease is still half of the man, but almost increases 4 times in them. Normally, a woman has about 1/8 the chance of a heart disease as in a man, but after menopause it becomes just half. So their risk increases 4 times. How does it affect? So these people will have a very different presentation to the coronary artery disease. They will have a longer presentation for a few days. They might just come to you and say, "We've got a flu-like thing, a little bit of tightness in the chest," and you might just interpret it as a common cold and just give them some, over-the-counter medications to just take home, which may not be the case. So any women above 45 who says has got a bit of uneasiness for a few days, you need to probe whether he or she has got any cardiac um, coronary issues happening with him or her. The best thing in this case is probably a CT coronary angiogram, because women by nature have a lower calcium load. So the CT coronary angiogram is very, it's really sleek and really specific in identifying positively, or it's got a very good positive predictive value for coronary artery disease in women. So I would say any women after 45 with a lower estrogen level has a higher risk of getting coronary artery disease, almost 4 times increase in them, still about half that of a man. And we need to tread very carefully. They will come with a longer history, they will come with a softer history, they will not complain of a severe chest pain, they might just complain of an occasional tightness in the chest. And rather than giving them some OTC medications, we need to consider a coronary disease artery angle in these patients.
Thanks, Dr. Biswarup. We have another question from Dr. Ivan.
Yeah.
First, he's thanking you for the presentation, and his question is, how can you manage angina case with HIV?
So it is a very standard practice. If somebody's got an HIV, he's got an angina, so he needs to get an angiogram done in a universal precaution pathway. And should he have a coronary artery disease, any hospital that is JCI accredited has a protocol in place to properly seclude these patients and provide them the right care. It is stentable, it is also operable. So somebody with HIV or people living with HIV status are not discriminated to not have their treatment. It is very much possible to put them through a protocolized way and put them through a cath lab where they can be sent in our hospital as well. We have a protocol in place where we isolate, segregate them, put them through the pathway, provide them the correct treatment. It can be a CI stenting, it can be a coronary artery bypass, and we are more than happy to support them in the most effective way. Okay.
Dr. Biswarup, we have a few questions from Dr. Dima from Ghana.
Yeah.
And first, thanking you for this elaborate presentation. And
Yes.
his question is, what is the direct relation between pec muscle spasm and
Spasm and
CAD?
coronary artery disease. So, pectoralis muscle spasm can often be misdiagnosed as what is a chest pain. So, we very clearly differentiate uh, cardiac chest pain from non-cardiac chest pain, as in non-cardiac chest pain will not have any elevation of enzyme marker. So you run a troponin test on them, a pectoralis muscle spasm will always return a negative troponin test, and you are more sure than not that it is not a coronary artery disease. So it is a pectoralis muscle spasm. The second question that you asked is, what is the first choice management option you would prefer? Should you find there's a direct link between CAD and pec spasm? CAD per se is not related to pectoralis muscle spasm. Somebody with a non-coronary chest pain has to be treated with non-steroidal anti-inflammatory drugs. If he or she has a coronary artery disease which is evidenced by rise in enzyme or an ECG finding, then you need to go down the angiography pathway where you decide whether he's up for an angioplasty PCI or he's up for a coronary artery bypass grafting. So I mean, I would not say there is a first choice management for a direct link between coronary artery disease, because one person might be presenting with a non-cardiac chest pain and have a coronary artery disease, but in that case we will treat the chest pain which is of non-cardiac origin rather than the coronary artery disease. Both of them cannot be presenting together and simultaneously. The third question is, can you elaborate the relation between optimal nutrition and CAD? So optimal nutrition is what is high protein, high fiber, low fat, low carbohydrate diet, which will decrease your coronary artery disease risk by almost 400% than what you have now. As a preventive measure, beyond the age of 40, regular blood checkup, regular blood workup, regular visit to your GP maybe once every 3 months is what you are doing to keep an observant look on your disease. You need to be extremely vigilant about your lifestyle habits. You need to have a regular walking habit. You need to be regularly exercising for more than 2 hours a week, which is about half an hour of exercise every day for all the weekdays, barring the weekends. And having done the right thing, manage your stress the right way, the right physical effort with the right diet, you can almost 80% of the time prevent your coronary artery disease before it reaches a level where it needs an intervention, either a surgery or a PCR or anything.
Uh, Dr. Vishnu, we have another question from Dr. Innocent.
Yeah.
He's from Kenya. And what are the other alternatives in place that could replace FET procedure?
So, I mean, I have not discussed about FET procedure, which is not FET is basically, is he referring to frozen elephant trunk for a aortic surgery? If it is so, it is a very specialized surgery. What is
Yes,
the
yes, he's referring to that. Yeah.
Yeah. So FET is a very specific thing for aortic dissection. In today's world, where you want to prevent a re-entry tear, because I do a lot of aortic work, I've been exposed to a lot of aortic work. It is almost mandatory to do a frozen elephant trunk. If it has not been done in the first place, then you can do what is called as an EVAR or endovascular aortic stenting. In the thoracic aorta, it is quite easy to do an EVAR because there are no major branches sticking up from the thoracic aorta. But when you come to the abdominal aorta and all your major abdominal vessels like your gastroepiploic, gastroduodenal trunk, the superior mesenteric, the renal, and the inferior mesenteric take up. So you need to have a patient-specific imaging, and then you need to contact one of those stent graft manufacturers with his imaging, where they will kind of design a specific stent for that person with the right bifurcations at the right level, which is a company called RTVN. I will send you the worksheet how you image the patient and share the worksheet, and then they will send you the graft which you can just go in through the groin and place the graft there. So an FVTA is a mandate. If not done, then your options are either a hot trunk or a hot elephant trunk, or what is an EVAR. Hot elephant trunk has fallen out of favor. So either it is an FVT or it is an EVAR. EVAR is an endovascular aortic revascularization, where you want to seal off the re-entry tear and you do not want the aortic dissection, which has been a kind of repair, to extend beyond the first re-entry tier. So yeah, alternative would be an EVAR. You have to take the CT scan imaging, image his all his major vessels, send the artwork, I mean the paperwork to the company. The company will design a patient specific graft and send it to you, and you need to deploy the graft with the help of either your cardiologist or cardiac surgeon or intervention radiologist, whoever in your hospital is doing that. If you send one such patient to us, we have a dedicated intervention radiology team, and me being in the aortic space for long, I can kind of pitch in and do the workup, and then we can kind of stent the patient or EVAR the patient. Yeah.
Next question is from Dr. Hiwat. Dr. Hiwat is from Ethiopia.
Yeah.
So, her question is a 70-year-old diabetic patient with end stage renal disease on hemodialysis for 3.5 years. He was on aspirin and atorvastatin, came with intermittent chest pain 1 week, and admitted
Oh,
with non-ST segment elevation MI. What
yeah.
should be the next steps?
Um, Non-ST elevation MI 70-year-old person who was on hemodialysis for 3.5 years. So I would put him back on single antiplatelet, which is aspirin. I will put him on unfractionated heparin, maybe 3 times in a day, for at least a 2 week period, so that he can tide over the acute crisis. Unfractionated heparin because he's got a compromised renal function, and I don't want to use any of those low molecular heparin or anything that recirculates in the body. Once his symptoms are kind of settled in about a couple of weeks' time, then we can plan uh, coronary angio on him, because whatever dye you give, the dialysis will have to take it away. And then we kind of decide whether he's somebody who's for a stenting or who's for a coronary artery bypass grafting. Because 78 diabetic, um, who's had an NSTEMI, is not the ideal subset to be right away put on the op table and kind of, So for frail old people that need a quick fix, stenting at times is a very good option to buy you some time and get you through.
Uh, so again, she's thanking you for the presentation, and we have a question from Dr. Dima. Another question: Can coronary spasm affect pec muscle spasm?
In one word, no.
Okay.
In a word, it is no. Um, Pectoralis muscle spasm will have to be picked up by a range of motion. If a local range of if a local range of motion, just give me a moment. It's an important hospital call. I'll just take this and I'll answer.
Okay.
Hi. So, I mean, pectoralis muscle spasm is going to be elevated by a localized range of motion, which is not going to affect your angina. An angina is not going to be affected by lifting your hand up or taking it back or doing what is the Gerber test, getting your hands behind your back and trying to move it will not affect your coronary spasm. And a coronary spasm has to be differentiated from pectoralis muscle spasm. Mm, I mean, it can be resource constrained setting, but we need to identify if it is a coronary spasm, it needs a treatment. If it is a pectoralis spasm, you just need to give the patient adequate non-steroidal anti-inflammatory devices, drugs. So
Okay.
NSAIDs are the answer for pectoralis spasm. Do a bit of localized range of motion, and the pectoralis spasm gets aggravated. The coronary spasm just stays as is.
Okay. So I think so far the questions are finished, and I request that if you have any, especially Dr. Burris, share the information, and
Yeah.
Dr. Biswarup will share his opinion and further steps about the patient. Dr. Hivat, okay, we have another question. Okay, the
Okay.
score name that Dr. Burris forgot was risk RFCL, risk factor weighted clinical likelihood model. For the patient, it was
It's
10%.
it's um CAS-CL or RFCL is an extremely old scoring system. We don't use it anymore. So you got to talk either in terms of a syntax score or an Euro 2 score. I mean RCRI, reverse cardiac risk index, or risk factor weighted clinical likelihood. Uh, no, this might be a little bit outdated scoring system. So we are not scoring anybody on the RFCL method. Uh, Euro score, yes, we can score them. Syntax score will need either a CT or a coronary angio, yes. Um, newer scores you want. There are RCRIs and other things, but this is a very there have been many caveats and pitfalls to this course. So this course will give you a very, very gross understanding of coronary artery disease. Uh, I mean, rather than doing an RFCL, I'd just put somebody on an aspirin 150 with a clopidogrel 75 milligram, preempting a coronary artery disease. RFCL will give you more false negatives than anything else. So is CASCL.
Right. So, Dr. Boris and Dr. Hivat, you can further how the patient is progressing. Please feel free to share your
Absolutely.
notes and get further guidance from Dr. Biswarup. Please don't hesitate about that.
No,
And
absolutely.
if
Happy to
we
help.
have, okay, yes, Dr. Boris will follow up, and Dr. Hivat, you also feel free to follow up how the
Sure.
patient progresses. And thank you, Dr. Biswarup. And if you have any questions, like, or any
Just
patient case to discuss, please share it on Jivo group with the relationship manager. We'll get a response from Dr. Biswarup.
great.
And if you want any other hard topic covered, we can request Dr. Biswarup for the next masterclass. He told me that he would rather prefer to cover a topic which the doctors want, but because
Yeah.
of lack of time and coordination, we selected. For next time, you suggest, and Dr. Biswarup will be happy to.
I'm very happy to, and I'm very happy with the interaction because RFCL is something that the generation before me grew up on, or RCRI, RFCL scores. They have multiple caveats. So better follow up the patient. Try to send him to one of your nearest facilities that is a CT coronary facility. Just do a CT coronary. Send us the report. We will do all in our power to give your patient the best quality of life rather than straight away traveling to India. Should he need any further support, we would be happy to help him long term as well. So yeah, that's my way of looking at it.
And in the last masterclass, also, Dr. Vishrup had reiterated that somebody coming to India is secondary, helping patient is
Is
primary,
primary.
and he's always happy to work with you, look at the cases together with you, or guide you so that
Yeah.
more and more patients can benefit.
Yeah, I'm also happy to host a few doctors should they want to once come to India for a quick time to spend with us to see how we manage coronary artery diseases and have an overview as to. I'm sure the interaction will be rich for us because even that somebody is asking for an RFCL score in 2025 was as much news to me. So I mean the interaction will be. We also need to appreciate that every human life is important, no matter how resource constrained it is. So we are very happy to host you here, and you can kind of explore our facility, go through our protocols, take some of the message or information or practice standards back home, and see how you can help your people. There is absolutely no shaming in asking any question. Every human life is important, whether it is resource constrained, super resourced, whatever it is. So, and I am very happy to have you because while I was training in India years back, we had one of our friends come from Nigeria as an observer with us, Dr. Jibril Khalil. He's opened up a cardiac center, if I'm not mistaken, these days in Nigeria, and his center is doing well. So these kind of interactions are not only for the patients, they're also helpful for doctors who kind of want to spend some time, have an observership. We'll be very happy to provide them.
Thank you, sir. And we will discuss with the Artemis team because many of our doctors request this. And
Yes.
even if we can do it for few, that
Yes.
that would go a
Come spend a little bit of time with
that
us.
would go a
Phenomenal.
great deal in capacity building. Uh,
Yes.
Thanks for sharing this information with us. And with your permission, I would like to conclude this session. And
Yes. Thank you so much.
thank you all.
Thank-
Thank you, Dr.
Thanks
Vishnu.
to all the attendees on a Sunday. It was a phenomenal attendance from all of you. Sorry about going a bit quick on coronary artery. Coronary artery is very close to my heart. I want to speak a lot. I know I've only got an hour. I can keep speaking on coronary artery for as long as you would want me to. Thank you so
Uh,
much.
Thank you, sir. And thank
Thank
you, everybody who attended today.
thank you so
Doctors
much.
get only Sunday for themselves and their family.
Yeah.
And then we organize master classes to steal your
Thank you.
Sundays. But thanks for regularly attending.
Thank you so much.
Thank you so much.
Thank you so much, sir.